There are three medications that tip us off that our patients are undergoing medicated assisted treatment for opioid abuse. What are they?
Find out today on Medical History Mysteries.
Hey, everybody. We're continuing our coverage of dental professionals are human too. And we're talking about opioid addiction this week. And there are three medications that will allow us to understand, without even knowing anything else about that patient's addiction, that they are undergoing MET, medication assisted treatment for opioid abuse. Tell us about it.
So this is a touchy subject because we have to realize that patients could be in recovery. They could be post, as the words come out of my mouth, sometimes people don't like them, but post rehab, or post opioid management, whatever the wording is. Let's just say they've been through a treatment plan, a treatment program. They're out on the other side now, okay? They're no longer dependent on opioids. They're no longer dealing with substance use disorder. Oh, I beg to differ. Just because you've been through recovery, just because you've been through a treatment program, just because, you're no longer experiencing substance use disorder, oh no, you're still at risk for substance use disorder. You're still at risk for opioid use disorder. It never goes away. It's part of your life forever. And so the one thing we need to understand as dental professionals is that we use opioids. Maybe we don't use them as often as some medical doctors prescribe them in pain management practices, but we use opioids. And so we have to be aware that a patient may be going through this. They may have gone through, again, a treatment program. They may have had an issue with opioids in their past. Okay, so what to do? Three medications are the things that you're looking for in a patient's medical history or in the state database. Every state's got one, right? Prescription drug monitoring programs. Every state's got one. You're looking at their medical history. You're looking at the PDMP for your state, whatever its name is, and you're looking for the three drugs. Okay, what are they? The first is Vivitrol. I'm only going to give the brand names because it's obviously it's going to be easier for you to spot them on the medical history or on the state's database. Vivitrol and Sublocade are two injectable drugs. Why dental professionals may not know about these is because they're not dispensed like a regular drug at a pharmacy. They're filled at a pharmacy that deals with these specialty drugs. So the medical doctor who's organizing your treatment plan sends a prescription to the central fill pharmacy. That pharmacy fills the prescription for the Vivitrol and Sublocade and sends it to the medical doctor's office. You, as the patient, never see the drug. You have to go to your medical doctor's office and get the injection there once a month. So you've got to plan on seeing your doctor once a month forever or until your doc says you no longer need the drug. That can be cumbersome for some folks. I get it. But getting the drug means you get the injection there. And for the rest of the month, you're blocked, meaning you could try opioids, but they're not going to work. Is it 100% guaranteed? As far as I know. But again, I can't say 100% for sure because I don't know everything I don't know. So you are blocked for the month. You can, recommend it. You could try opioids. They probably won't work. Okay. But that is outside the typical get my prescription from my doctor, go to my pharmacy and fill it. My pharmacist may not even know I'm on these drugs. But that's why pharmacists are instructed to check the database. That's why we as prescribers are instructed to check the database so that the medication, if it's on board, will be there. Now, sometimes it varies by state. I'm not going to lie. I've seen instances where it wasn't listed because the state law at the time said, no, that's not information that needs to be shared. To my understanding, that most of those laws have been repealed now. However, I would look first, okay, and make sure the patient's not on these two drugs. But let's say it's on it. Let's say you look the patient up, and there they are. Okay, did you look the patient up? Do you look up every patient? Hey, it's time consuming. It's not user friendly. I don't want to do this. I get it. So if your state allows someone else in your office to do it, fine. But you have confidence in that person that they will be able to look the patient up and find the information because you're going to rely on their information and their work. Well, why, Tom? It can't be that hard, can it? Patients like to give wrong names. Patients like to give us misspellings of names. Patients like to give us old addresses. Why? Would they be trying to subvert the system? Maybe. So you've got to rely on that person in your office or rely on yourself to be able to find that patient in the system and look at their medications. And if you see Vivitrol and Sublocade in there, then the conversation doesn't even have to happen. You know not to give them opioids, period. What if they ask you for an opioid? Then you can say, well, look, I looked in the state database, or I looked on your medical history, you're taking this drug. Obviously, you and I both know you can't use an opioid. What's the third drug? The third drug is Suboxone. Suboxone has a completely different distribution channel. You get it typically at the clinic where you see your doctor for your treatment. It's dispensed directly to you. Again, not through a pharmacy. So you get the medication, you take it home. The problem, if there's any, it's a good drug, but if the problem is any with Suboxone is you've got to take it yourself. You're your own advocate. There are going to be days when you don't want to take Suboxone. There are going to be days when you have to make that fight live in your brain. One part of your brain is saying, hey, we got to put that film under our tongue because we may want to get high. And the other part of your brain is screaming, no, we need to get high today. It's a bad day. We need to do something. So imagine having that internal struggle every day and realize the fortitude, the willpower it takes to want to put that film under your tongue. It doesn't take much to capsize that boat. So again, I'm looking for Suboxone on the state database. I'm looking for it on your medical history. And if I don't see it, fine. But if I do, I know not to give you an opioid. And I know what to say when you ask me for one, if you do.
Wow, that's really great advice. So maybe you take a little Post-it and you put those medications on a Post-it and you keep it inside a cabinet, because sometimes it's nice to have a quick reference for us to remember what we learn here at Medical History Mysteries, and things that you can bring back to your practice and make it an easy, quick reference for you so that you can be a better clinician for your patients. So keep your eye out for those three, because it will tip you off to a whole portion of their medical history that they might not disclose.
One more thing, Pam. Let's say you decide that database is ridiculous to use, or you know what, if the patient doesn't tell me that, that's their problem. Again, as many of you know, I've served as an expert witness for years now. The litigation around this is frighteningly quick. I never told you, but you never looked. You prescribed an opioid, you capsized my recovery. Now I'm addicted to opioids again. And this has ruined my life. And I'm going to sue you for punitive damages from misfeasance, which may be considered malfeasance depending on what your motive was. You don't want to go down that road. Just take the time or delegate it and find someone who's competent enough to do it for you, and just remove yourself, extract yourself from that situation.
Oh, yeah, absolutely. Protect yourself, especially before you write any prescription. Make sure that you're writing the correct one, the correct dosage for the patient. Make sure there's no drug-drug interactions with medications that they're currently taking. But also, you need to make sure that that drug is safe for that particular patient. And so there's a lot of responsibilities that go with any prescription that we may write for our patients. So great advice once again. And everybody, we will see you all next week on Medical History Mysteries.
Take care, everybody.